Hi, and welcome to this PowerPoint presentation on HIPAA compliance basics. Now, you might be wondering why we need a whole PowerPoint on this topic. Well, good question, and it's an important law. It's a law that, as you will see, will affect a lot of the work that you do as a health services administrator, and it affects the organization that you work in. And so it's important for you in your role to understand what are the requirements so that you can make sure that your organization is complying, and also what's not a requirement. Because over the years, a lot of myths have come up of things that you can and can't do, because of HIPAA. So if you know the source and you know the accurate information, you'll be better able to perform your job. It's not a boy or a girl, it's a HIPAA law. It was born in, get this, 1996. So it's not as recent as you might think. Some of you were probably not even around in 1996, but we'll put that aside. The biggest thing that drove the HIPAA law, especially in the early days, was this concept of portability. So when you see the acronym HIPAA, the P is for portability, which means being able to take something with you, right? It's carryable. And back in the day, health insurance was primarily given to employees or provided to employees by an employer. So there was really not a great market for purchasing your own insurance policy. If you were not employed, you probably didn't have insurance. And if you did, you purchased it at an astronomical cost. So everybody depended on their job to provide insurance. But the issue was that if you changed jobs and there was a waiting period before you would be covered in your new job, then when you became covered, anything that you had before could be excluded from coverage because it was considered a pre-existing condition. The same thing happened if you didn't have insurance and all of a sudden you got a job where you were offered insurance. Let's say you had a motor vehicle accident in the past and had some surgery. Your new insurer could say, well, you know what, we're not going to cover anything that has to do with that surgery that you had because that's a pre-existing condition. So this led to people basically being held hostage by their jobs and their insurance because they were afraid to change jobs, have that waiting period, and then not be covered for certain things. So this was long before the Affordable Care Act, which made it possible for all of us to go into the market and purchase insurance directly if we weren't covered at our jobs. So P for portability, a very important and novel concept that was very freeing to employees, allowing them to change jobs and not lose their coverage. The other big thing surrounding the early HIPAA rules, which for us is now, like a blast from the very, very past, was administrative simplification. In this digital age, it's kind of hard to believe that everything was paper-based. Think of, if you work in healthcare, all of the little things that happen as part of providing care to patients. And imagine all of that being paper-based. Kind of hard to wrap your mind around it, right? But that's how it was. So when a provider saw a patient or a hospital had a patient, the billing was done on paper, and eligibility, checking a patient's insurance coverage, was done by telephone with long waits. Referrals were very paper-based, and there was no standardization for any of this. So in other words, if you were submitting a claim for a particular service, one insurance company might ask you to do it one way and report certain things in a particular fashion, and another insurer required it in a different way. So it was pretty much a crazy show, if you will, where I remember seeing people who had like little notebooks that said, well, wait a minute, Cigna wants me to do ABC, but Aetna wants me to do something else. So HIPAA wanted to simplify all of that, get rid of all the paperwork nightmare and all the headaches that everybody had back then, and make everything standardized so that there was one way that claims looked regardless of who you were billing. There was an easy way to check eligibility, and administratively, you could free people up to take care of the actual patient, right? Hello, there's a patient at the end of that, and not get so bogged down in the business of healthcare, which is still important. So the administrative simplification aspect was very central to how they set up this law. HIPAA, and I'm going to go back to the acronym HIPAA, stands for Health Insurance Portability and Accountability Act. Is not HIPAA, HIPPA, because that's like hippopotamus, right? And there are no animals in healthcare, or at least in this presentation. So forget about that. Know your acronyms because you will look uninformed if you call it HIPPO or HIPAA with two P's. HIPAA is actually an umbrella, right? So underneath all of the HIPAA law are specific rules that cover aspects of the law as it developed over time. So they had a great idea. Portability is important. The accountability aspect, right? The administrative simplification, but we also can't make everything electronic and not look at holding providers and plans accountable for how they use all of this digital information that they're going to start acquiring and transmitting and storing. So the accountability aspect is important. How are we going to do this? Well, we're going to do it bit by bit. And they released rules that covered different aspects. So first was the privacy rule that went into effect in 2003. So you can see there's quite a lag from a law becoming a law, right, 1996, to the first actionable how-to of the implementation becoming effective in '03. So that's when everybody had to start complying with that aspect of the HIPAA law. Next, we have the security rule, which was required by 2005. So they worked out all of the details, and effective in 2005, providers had to comply with those requirements. And then the last part under the HIPAA umbrella is the breach notification rule, which became operational, if you will, in 2010. So we are going to look at each of these one at a time and talk about the different aspects and how they relate to you as a healthcare manager and how they relate to you as a patient, because sometimes you are a patient. First, let's look at a few definitions so that we have a level playing field and you understand what we're talking about and what we're referring to, because we know that healthcare has a lot of phrases and words and acronyms, right? We talk about CMS and HIPAA and all of that. Okay, so definition. First one is a covered entity. A covered entity is defined as a health plan, a healthcare clearinghouse, or a healthcare provider who conducts certain electronic transactions. Now, I know you can read that for yourselves, but I wanted to make sure I stressed certain words. And what are those transactions? There are a bunch. But specifically, eligibility, issuing referrals or other authorizations, submitting claims or checking the status of claims, receiving payments from insurers for those claims, and several other transactions. So let's stop for a second and look at this. A covered entity is the person, if you will, who must comply with the HIPAA law. So if you're not a health plan, you don't have to. If you're not a healthcare clearinghouse, you don't have to. If you're not a healthcare provider who conducts certain electronic transactions, and there's that list, what's on the slide and more, then basically you're not a covered entity and HIPAA doesn't apply to you. Now comes for the big however. It's very hard not to perform any of these electronic transactions. So let's say that you find somebody, a provider who's like maybe in a small town, um, not very electronically oriented, does everything on paper, keeps paper charts, does eligibility by phone, submits his claims by paper. That's going to be hard to find because even Medicare, who is the largest payer, Medicare requires providers to submit their claims electronically. There are a few exceptions and you have to apply for an exemption, and so it's going to be tough to find somebody who does not have to comply with this. So health plan, clearinghouse, healthcare provider, electronic transactions, that's the key. And just like motor vehicle laws apply to the driver, not to me as the passenger, but to you as the driver, the HIPAA law applies to the covered entity. What we're talking about under the HIPAA law is protected health information, or PHI. This is information that's created or received by a provider, health plan, or clearinghouse. Important point, it's related to the treatment, payment, or operations of healthcare. Well, we know what treatment is because that's information regarding taking care of a patient. So an operative report, or the patient came in for an appointment, that visit note is related to treatment. A prescription transmission is related to treatment. So find me somebody who does not do electronic prescribing, right? Payment. Perhaps the information is necessary for the processing of the payment of healthcare services. So, for example, a provider, a cardiologist, contacts a primary care physician and says, I need information about the patient so that I can process my visit, my claim, my whatever. That's related to payment, and I'm going to come back to that in a second. The other category is operations. Operations has to do with the business of healthcare that doesn't fit into the other little categories, right? So there's a lot of regulation in healthcare. There are utilization management reviews. There is case management. There are medical chart audits. There are a bunch of things that happen that don't really reflect treatment per se or payment per se, but they are peripheral and they still require the sharing of health information, protected health information, in order to be accomplished. PHI is also kind of forever. So it's old information, it's current, it's future information, it's anything that has to do with the health of a patient. In addition to that, key point here that we're going to talk about again is that it identifies the patient or could reasonably identify the patient. Then it's information that's electronically transmitted or maintained in any other form. So you're getting the idea that PHI is big. It pretty much touches everybody, and it has to do with just about every aspect of healthcare. Maintained in any other form is an interesting point because a lot of times, all right, I remember the paper world. So I think paper, I think electronic, but those are written forms of PHI. There's also verbal. So two people can have a conversation about a patient, talking about information on their treatment that's happening in the present. And if that conversation identifies or could reasonably identify the patient, then it's PHI. So something that maybe you didn't think about is that a conversation with somebody in a hallway, in an elevator, is PHI. Of course, with the advent of more electronically based transactions, it also reflects electronic PHI. Next, I want to make sure we understand the concepts of use and disclosure, right? So use means sharing, examining, applying. It's information that you are accessing for whatever reason. Disclosing means giving it out to somebody else, divulging. So these two things are central to the privacy law because you can access information and not disclose it, but you're still doing something that needs to be permitted under the HIPAA law. Why are you accessing it? For what purpose? And what are you accessing? So those are all of the things that you have to kind of think about as you think about use and disclosure. So we talked about HIPAA applying to the covered entity. And covered entities do a lot of things. So if I wanted to get away from HIPAA and maybe not being a covered entity, maybe I could subcontract certain services to somebody else. And that way, I'm not the one doing them. It's their problem. It's kind of like, the hot potato, poof, and I send it to you, and now I'm not responsible. Wrong. Because a business associate is that organization. It's the organization that performs a function on behalf of a covered entity. Maybe it's a billing company. The other piece of that is that their services, that business associates' services, require the use or disclosure of PHI. So while a business associate could be the telephone repair person or the janitor that cleans the office, the services that those associates provide do not require PHI. So you need to look at a business associate as someone, person or company, who does something. So billing company, transcription service, practice management company. Now, generally an attorney wouldn't need PHI, but if the attorney is defending a provider from a malpractice suit, then he or she is going to receive information and know information about that patient's health. Same thing with an accountant. By and large, accountants don't look at anything having to do with patients, right? They're focused on the financial side of business. But if perchance they do, then they are considered business associates. Now, a business associate usually has a contractual relationship with the covered entity. So I'm doing this for you, and Professor Parker can explain all of the nuances of those contracts. But in addition to that, HIPAA requires that the covered entity have an agreement, a written agreement with a business associate called a business associate agreement that extends all of the rules that the covered entity has to comply with, extends those to the business associate. So in other words, the protections, the privacy, the security, the breach notification, all those little aspects under the umbrella of HIPAA, not only does the covered entity have to live with them, but the covered entity has to contractually enforce or bind the business associate to complying with them as well. So nobody gets away from HIPAA just by subcontracting something. Everybody's got to comply with it. Next is breach. So this is an unpermitted use or disclosure under the privacy rule that compromises the security or privacy of PHI. We are going to look at what's permitted, and anything that's not permitted is obviously unpermitted and a breach. You might be familiar with breaches because in today's day and age where we use electronic payments, right? And you sign up for things, you give your passwords. Well, no, you don't give your passwords, they get stolen. But you enter your credit card information or banking information, and then you might get a letter in the mail that says, hey, we detected a breach and your account information may or may not have been accessed. right? So here's what you need to do. And the company gives you information on that. And that's not even having to do with healthcare. That's just you bought something on a website or have an app where you entered your banking information, and they're letting you know that there was an unpermitted use or disclosure of your information. So imagine if it was your health information. All right, so we looked at those definitions. Now let's move into what does the privacy rule say? Well, the privacy rule has to do with the aspect of HIPAA that defines what is an appropriate or inappropriate disclosure of PHI. And what does that mean for the patient? The privacy rule extends some really interesting rights to patients that we're going to cover in another slide or two. So remember, privacy rule has to do with the use and disclosure of PHI. What's permitted? Well, who can you give information to? Obviously, the person. There may be some very narrow reasons why you would not, and especially in the psychiatric world, if I'm trying to remember some of them, like if there's a chance that a patient reading their psychiatric note, it might destabilize the patient or make them suicidal or something like that, then there are reasons why you would not release information to the individual, but those are very, very small and rare. So the individual is always entitled to information about his or her healthcare or healthcare services. Obviously, you are permitted to give out information for treatment payment or healthcare operations, so TPO. Now, remember we talked about the cardiologist who, for some reason, doesn't have the right insurance information or whatever on the patient and contacts the primary care office and says, hey, can you send me the patient's insurance card? Can you send me whatever? Technically, because it's for payment, healthcare services payment, you don't need the patient's permission in order to say, let me send you that information. So treatment, payment, or operations. By the same token, and as a practice manager and working with medical charts as long as I have, I find it interesting that anytime you request information about the patient, let's say the patient was in the hospital or the patient went to another provider and you want to get those records, you need the patient's signature on an authorization form. You really, really don't. Not under the HIPAA law, because for treatment, payment, and or operations, you can do this. But every organization can impose its own policies and standards, and they can be more strict than what the law says. You just can't be any less strict. So that's why usually they require the patient's signature on an authorization. The third thing, or the third time that you can disclose information, if it's de-identified. So we said that PHI is information that identifies or reasonably could identify the patient. Well, if all of the things that identify the patient are removed, then that's technically not PHI. So think about what are the things that you would think that come to mind that identify the patient. This is where I miss being able to see you guys and talk to you, right? Their name, obviously, right? If you had the patient's address, you might not identify the patient, but you reasonably could. If you had their phone number or an email address or a social security number. So there's a list of 18 identifiers that includes even zip codes. So let's say for data aggregation purposes, you wanted to say something about, or you wanted to look at where your patients live. You could not look at the entire zip code, but you could look at the first 3 characters of the zip code and disclose that. So I have, 5,000 patients in zip code 333, but that's it. So whatever it is, You're not going to be able to be that precise. And there are rules about how far down you can drill, and if it's a larger metropolitan area as opposed to a smaller area. Vehicle identification numbers, license plate numbers, IP address, biometric identifiers like finger and voice prints. And I'm sure that now, well, photographs are also included. So those of you who have that face recognition on your phones, I mean, that's an identifier. So there are things that if they are stripped from the health information, then it is no longer PHI. It's considered de-identified, and that information can be shared. There are times where providers want to use information perhaps for research purposes or for public health reasons to be able to track illnesses or, I don't know, vaccination rates, things like that. You can do that by creating a limited data set, which is de-identified health information. And then you can, study that. Okay. Next concept is called minimum necessary. So the covered entity has to make an effort to limit the use, disclosure, and request for PHI to the absolute minimum that the other party would need to accomplish its purpose. So if somebody asks you for a copy of a patient's chart because they are looking at some specific services and the medical necessity of those services, really? You need the whole chart in order to do that? Or do you need the requests and the notes and the documents related to those services? That's more likely. So we don't necessarily respond blindly to requests of information, but we try to make sure that whatever we are allowing somebody to see or access, or whatever we allow to be disclosed, is just the minimum of what is needed to perform a function. Incidental uses and disclosures are exactly that. These are disclosures that occur just kind of accidentally. So you're doing something permitted under the privacy rule, and somehow information gets overheard, let's say, because that would be plausible, right? Maybe you are talking on the phone to somebody regarding a patient in your office. Well, number one, you would make sure you close your door if you're in a trafficked area, right? So your door is closed, you're on the telephone, not on speakerphone, right? And maybe the door gets opened. Maybe the walls are thin. And somebody overhears you talking about, somebody's heart surgery, and there's enough identifying information that they'll know who you're talking about. You refer to Mrs. Smith, you refer to the patient in room 3, whatever. Well, you're doing something permitted. You closed your door, you're not on speakerphone, so you did the right thing to limit the chance that somebody is going to overhear this protected health information. But they still did. And I know I've been in doctor's offices where the walls are thin, and I could hear like the consultation next door. So, you just put in your earbuds and, don't listen. But that would be an incidental use and disclosure. So, you have to do, as a covered entity, you got to implement safeguards. And again, minimum necessary, so you're only sharing what you need to. But you do what you can to minimize the chance that that's going to happen. And remember the definition of PHI. So if the information is not identifiable or reasonably identifiable, then no harm, no foul, right? I mentioned before that the HIPAA law addresses patients' rights and also provides patients with new rights regarding their health information. Receiving a notice of privacy practices. So one aspect of the law said that every provider needed to prepare a document called a Notice of Privacy Practices, which in a sense explains to the patient how that patient's health information is used in their practice, and gives the patient the information about, well, if you have a question, if you have a complaint, if you have an issue, here is how to address it. You probably have signed these and never bothered to read it. They're all usually pretty much the same. There may be slight nuances that differ according to the providers, but basically it's a standard document. A lot of times, I know I've been to doctor's offices where they've given me a document to sign that says that I received this notice when I did not receive it, or they might give me something to read, but I've got to give it back. And sometimes we sign without knowing what we're signing. You should probably stop and take a minute to read through or skim through a Notice of Privacy Practices so that you have a sense of what's included. Next is the patient has a right to inspect his or her own record. Now, inspect is the wording used in the law. That doesn't mean they're conducting like an investigation, but you have a right to review your records, and you have a right to request a copy of your records. Now, as you're going to see with these rights, the providers will put together a framework for how that happens. You just don't walk in off the street and say, I want a copy of my record right this very minute, stop what you're doing. They might say, well, you have to request it 30 days or fill out a form or whatever. So they can put a process together, but the bottom line is the patient has a right to receive a copy of his or her medical records. Patients also have a right to request an amendment or correction to their record. Well, that's a cool one. So if there's something incorrect in your chart and you know about it, then you have a right to request that the provider make a change. This didn't happen a lot, but with the use of templates in medical record documentation and copy-paste, I've seen it where somebody's information is incorrect, and the provider might refer to something that really does not apply to that patient. It's happened to me that I had a test done, and in the report, it mentioned the medications that I supposedly took, and I did not take those. So I requested an amendment of that report, and I said, I do not take these medications. Those are not mine. So again, there will be a process for how you request the amendment, but you do have a right to do that as a patient. And as a healthcare manager, you need to know that you will get or may get these requests from patients according to the framework in your organization, and we need to make sure that those requests are honored. Now, the provider does not have to honor the amendment. The provider might say, you know what, according to me, yeah, you do have X, Y, or Z, or hey, you do take that medication, and I am not amending your record. Either way, there's got to be communication between the practice or the provider, I think in terms of practices, right? Between the provider and the patient. I got your request for an amendment, we fixed it, or we're not going to fix it, and here's why. The patient has a right to request an accounting of disclosures. This is cool. I've never seen anybody ask for it, but you know what? They could. You could. I could. So remember how we said that a permitted use or disclosure is for TPO, right? And that was, I can't hear you, treatment, payment, and operations. Anything else requires the authorization of the patient. So if it's not for TPO, then I, as the patient, need to clear you, provider, to give out that information. Let's say that I am trying to purchase life insurance, and the life insurance company wants to know about my medical history, I would need to authorize that disclosure to the life insurance company, and that would have to be in writing so that that company could receive my information. It's not regarding treatment, right? Life insurance is not regarding treatment or payment, not payment of a healthcare claim, and not operations. So that's something that I, as the patient, would need to authorize. So a request of accounting of disclosures is anything that was disclosed that was not TPO and pursuant to an authorization. So this is where organizations need to keep track of any oopses. And you'll see later that once the breach notification rule morphed in 2010 into what it is right now, the accounting of disclosures is kind of like, well, you're going to get it anyway. The other thing that patients have a right to do is restrict the uses in disclosures. So maybe you don't want to agree to certain information being used by your provider. Then you can do that exactly in writing, like it says on the Notice of Privacy Practices, but you can say, I don't consent to your leaving messages for me. I don't consent to your using my information for this particular purpose. Again, sometimes the practice or the provider has to say, sorry, we cannot comply with your request to restrict, but by and large, you have the right to request it. Authorization for non-TPO disclosures, we talked about that. That's a specific right that I as a patient have, that anytime someone wants to receive or disclose your information, you have to say it's okay. Confidential or alternate communications. Now this is interesting because you can, let's say you share a phone. This doesn't happen now because everybody has a cell phone, right? And only you listen to your voicemail, maybe. But if you had a house phone with voicemail and you had several roommates, you may not want the doctor's office or the hospital calling and leaving messages, very detailed messages about your healthcare stuff, where your roommate might be able to pick up that voicemail. So you could say, don't call this number, only call this number, or only send me email. So you have as a patient has the right to request that communications be made a certain way so that you can protect who hears about your health information or learns about your health information. The same thing would happen if you don't want certain people. Maybe you don't want your parents to be able to call. I know sometimes parents, right? You're 20 years old and your parents are still doing things for you, but maybe they think they can call the doctor's office and ask questions about you. Well, technically you're over 18, so you can even say, and I don't want you to share this information with my parents. And the provider will make a notation of that. And the last right is, of course, we have, as patients, we always have the right to complain, right? And if we didn't have the right, we'd complain anyway. So if you have, or a patient has an issue with how information has been used, accessed, disclosed by a provider, the patient has the right to make a complaint, and there needs to be a complaint process for this, which is part of the HIPAA rule. So all of these things that you see on this slide are issues that your organization would have policies and procedures that spell out, okay, here's what you do when Mr. Jones comes in and says, I'm here to inspect my medical record. Here's how you handle that. And there are parameters in place, there are time frames in place in the law and by the organization that says, you know, we have to do this within 30 days or 60 days. And so those things are all spelled out. Chances are you will work for a company that has this framework established. It's been a long time. They really need to have it established, right? But Sometimes practices start or medical businesses start recently and they know about HIPAA, but they're only thinking the very basic part. Okay, so don't leave medical documents laying around and don't talk about people's healthcare stuff in the hallway. Yeah, but there's more to it than that. The last thing that I want to talk about under the privacy rule is marketing. Of course, marketing is defined as communication that encourages the recipient to purchase or use a product or service. So, let's say that a practice has vitamin supplements and they sell those. Not unusual, right? And there's something that they sell that is for a particular health condition. Maybe it's for diabetes. And someone related to the practice wants to run a list from the medical practice's electronic medical record system of all of the patients that have diabetes so that you can market to them this new supplement. Well, that sounds like a no-brainer, right? Because these are my patients and my staff is pulling this list and the communications are coming from me and they're buying these supplements from me. Not so quick, because that's really not a permitted use and disclosure for accessing somebody's health information. But in your notice of privacy practices, you could say, and by the way, we do marketing and we receive remuneration, obviously, because you buy these supplements from us, and we may use your health information for this purpose or that. You need to be able to give me consent for that. So you need the patient to agree to that particular use and disclosure of their health information. I'm not even going to touch selling a list to anybody else, right? I mean, we know that this is a no-no. So that doesn't mean you can't do it. You could produce a list, but you would need to ask every one of those patients. Maybe it's not your supplement, it's somebody else's supplement, and you think this is great. You would like all of your diabetic patients to have this. Well, you could put a flyer or other communication in your office. You could put it on your website and let patients opt in. Or you could have authorization forms ready and say to the patient, listen, I really think you would benefit from this. Is it okay with you if I give them your contact information? And if the patient signs, you're good. Of course, and the way things have changed, remember this law was written a very long time ago. So usually there'd be like a QR code in the office, and the patient would scan it and then opt in directly to receive those communications. But a lot of different situations can arise. Just know that marketing, you need the patient's permission. All right, so we've gone through the privacy rule. The security rule, if you remember, was put into place in 2005. So now think about the fact that we've gone from a largely paper-based healthcare world into the electronic world, and we're still in the early stages. But now there needs to be attention to the protection of all of that electronic health information. So the security rule was in place. This rule defines the standards for transmitting and storing healthcare information to make sure of its integrity and confidentiality before, during, and after transmission. So there are a couple things to look at here. One is, and I guess it's something that we probably don't really think about, but I don't lose any sleep, really, that the information in my medical record at my doctor's office could be changed, right? And that has to do with integrity. So, you remember those little movies and stuff where, somebody hacked into the school's computers and changed people's grades and things like that? If only, right? Um, so what if somebody could get into your chart and change something about your health care, or monkey around or disappear documents or put documents or things in there that didn't really apply to you? I don't know. I don't think about that stuff, but integrity is important. So for any healthcare organization, that the information that you store electronically about a patient needs to be undefiled, if you will, by anybody. Why? Well, because number one, it's a legal record. Number two, because providers are making healthcare decisions for that patient based on the information in that chart or in that system. So, we take it as a given that that information is pristine, and it is the way that it was stored or documented by a licensed professional. But that's a security aspect. Same thing with the confidentiality. How do you know that information, as it's traveling from a provider's setting somewhere else, isn't compromised, viewed, snagged by somebody wanting to use this information for a bad purpose? And so the security rule, and I'm going to tell you now, I am not techie, not even a little bit. So I will tell you what I know. And if you're a technologically oriented person, good for you, then you know a lot more than I do about all the nuances of security. But hey, as healthcare administrators, we don't need to know that. We need to have people who are talented and qualified, and we need to make sure that there are policies in place for the end result, which is I need you to ensure integrity. How you do it, Mr. or Mrs. Technological, that's up to you, but I need you to do it because I need to make sure that my organization's data is secure. So one big thing under the security rule is the requirement for the organization to conduct risk analyses. And I probably should have made that plural because this is not a one and done thing. This is a one and forever thing. If you've looked at anything about laws, you know that sometimes they use very squishy language, right? It's not precise. It's just periodic, reasonable. Well, what's periodic? Is it every day, every week, every month? I don't know. Same thing with a risk analysis. Organizations are required to evaluate the risks and vulnerabilities in their electronic environment so that they can spot or anticipate anything that could happen and implement security measures to protect against reasonably anticipated threats or hazards to the security or integrity of EPHI. So it's not possible to say with what frequency an organization needs to do this. It needs to be appropriate to the organization and the analysis. So, again, not technological. If your organization conducts an analysis and identifies that there's very low probability based on the work that you do, that there would be any risk or vulnerability in their system, you might decide that this is something that you're going to do annually or every 6 months. Some healthcare businesses might find or be in a situation where they need to do this risk analysis much more frequently than every 6 months. Maybe they need to do it monthly. I don't know. But that's got to be spelled out in the policy of your organization and in the risk analysis report that is done by somebody who is qualified to do this. So risk analysis is basically kind of being on the lookout for anything. And of course, situations are changing all the time. So that makes this even more of a periodic, depending on what's going on in the world in your community. Evaluating the risks and vulnerabilities. Why? Because you need to be able to protect the information that you have there. Think about your house or where you live. Do you only check to make sure that doors and windows are locked, every so often? Or do you check every day when you leave to make sure that everything is locked up and when you go to bed that you are secure? Same thing. And if you lived in an area where there was higher crime, you might check and implement other safeguards to keep yourself and your family safe. So same kind of concept. Vulnerability means a system flaw or weakness that could be exploited and lead to a breach. And threat, just so that we get our definitions down, threat means the potential to trigger or intentionally exploit a specific vulnerability. So now we know that there are techie people that use their powers for bad, right? They know things, they understand, they have the hacking mentality to want to exploit. Now, every so often you know that there are companies that try certain things because that's part of their whole protection. So they're trying to see, all right, can I get phishing scams, PHIS, right? Phishing scams, where it looks like somebody in your company is asking you to click a link or to provide your password. They might do these things internally to see how many employees really do click and provide their password so that then they can provide more education. So these might be things that the organization does intentionally to spot vulnerabilities and be able to address them and implement safeguards, or they can come from outside. So the risk analysis, know that it needs to be done. It needs to be done with the frequency that is appropriate to your healthcare business, your healthcare environment, the environment as a whole. Sorry that I can't be any more precise than that. And then there are 3 areas where safeguards need to be put in place. So the first is administrative safeguards. And there's a little bit of overlap, I think, at least to my understanding of the different things under this area. Again, stuff that we all probably take for granted, but good to know. I mean, when you hire people, there's a process that they go through, right? Before they can have access to your company's electronic systems. So that whole, I just can't walk in someplace and say, "Hi, I'm a new employee. Can you give me a password?" There is or there should be. Let's stick to that one. There should be a process whereby new people are cleared for accessing systems. Now, let's go back to the concept of minimum necessary, because I probably should have mentioned that back then. The person who answers the phone and books appointments has a specific role. The individual who works, a nurse or medical assistant who works with the clinician, has a different role. Do both of those individuals, and then of course there's the clinician, right? So you look at those 3, the person who answers the phone, the person who works with the clinician, and the clinician. What kind of information do they need access to? Would you say that the person who answers the phone needs to be able to look at lab results and x-rays and hospitalization documents and all of that? No. That person doesn't need that. Should the nurse or medical assistant be able to document a visit note, like actually what was done during the visit? No, because those people are not providers unless the nurse has that designation. And the clinician has specific permissions, if you will. So that goes back to minimum necessary as well. You have to look at the roles that people will play in the organization and clear them for the specific level of access that they need according to their job requirements. Now, small organizations, sometimes people wear a lot of hats, but in very large companies, it's possible that the person who answers the phone and books appointments doesn't do anything more than that. Well, then that individual should not have access to certain things that are health information, regarding that patient. So the whole process of clearance, promoting people, well, now somebody needs a different level of access. Stuff that you probably don't think about, but it's important, and it's important to security. Access controls, determining who and how has access, the whole system of, is there going to be a password? How is that going to work? The configuration of the system. What happens when there's an incident? What is the process for handling that? Contingency plans. So what are the safeguards in case of some kind of an emergency? The power's out, the internet's down, you cannot enter the electronic system where you document or where you take care of your patients. Well, what's the plan B for that? Because we can't just close the doors and say, sorry, we have no internet. Come back when our computers are up. You might be able to do that at like the auto parts store, but not in a healthcare environment. So what does that look like in the organization? Disaster recovery. So maybe there's been a computer crash. How do we make sure that the information that the organization has is protected and not lost? I could tell you stories. There's a requirement for training. So how frequently, what kind of training, how is that going to be done? And then termination, think about when somebody's leaving the organization, how do you, or do you, is there a system for making sure that that person is deactivated across all of the platforms to which they had access? So those again are policies, things that need to be thought out in depth in advance, and you as a healthcare manager would probably have feedback or input into some of these things, especially if you experience issues like a crash, like a power outage or whatever, that you might say, wait a minute, let me go back and look at our company policy about this. And I see something that wasn't addressed. It happened, and now what do we do? The second category of security safeguards are physical safeguards. And those, kind of make sense, right? Keeping things locked. Would you keep your servers out in your waiting room? No. So how do you physically protect the systems that are used to connect to your electronic world? So even media control. What can people download to a flash drive? What can they upload or install on systems in a workplace? Viruses can come in that way too, right? People can steal information. So what are the company policies and what are the safeguards that when you put a flash drive in and you try to upload something, the system stops you and says, hey, you don't have access to that, or you don't have the permission to do that. Physical access to devices we talked about, to devices, to workstations. Device security. So what kind of security is installed on your computers at work? If you're using any kind of tablets or other devices, what are the security protocols there that do not allow you to download things or upload things? Are there backups? Where is information stored? And how is that storage protected? And then what happens when you need to get rid of a computer? It just doesn't work, or you need to get rid of a tablet or any other electronic device. How is that information, any health information that could be stored there, how is that wiped out of that device? Last one, technical safeguards. We're in the deep water, right? For somebody who doesn't do like electronic data authentication, right? So how do you make sure that information really is legit, that it's not been tampered with? We know, I hope you know, that when you touch anything in an electronic system, it is logged. It's like being on camera 24/7. Where you click, what time you clicked it, what you looked at, what you changed is all recorded for posterity. So all of that information is received and kept by the organization and should be reviewed by algorithms or whatever means to make sure that information is not corrupted, not inappropriately changed, deleted. So how is authorization granted to people? What are the password policies? If you're like me and you work for an organization that requires you to change your password like every, was it 90 days, and it can't be the same password that you've used like 2,000 other times, right? And you're constantly having to remember a new password. I mean, those are all mechanisms that the organization, technical safeguards that they have put in place to minimize a vulnerability or the potential for a threat. Um, Even when you give other people access to your company's system, maybe they are case managers, maybe they're other providers. How does that process work? The process of encryption, when you're sending information to others and it contains health information, how does that work? And then, of course, audit controls. And that's big because that has to do directly with the risk analysis part. So there needs to be an audit process that happens where potential intrusions into the system, anything abnormal is spotted by whatever means, see, I'm in the deep water here, and can be acted upon from a security standpoint. So, security rule has specific requirements for the risk analysis and all of these different safeguards that are meant to protect the data that's in there and to make sure that only people who are authorized can access it, use it, disclose it, and how that all happens. So lots of policies, lots of procedures, lots of rules. All right, last part. I don't know if you need a break. I feel like I need a break. Okay, but we'll get through this. It's not, there's not too much longer to cover. So breach notification rule. I don't want you to think that HIPAA waited until 2010 to say, hey, you know, what happens if somebody leaks information or breaks into the system? They didn't wait. There were breach rules throughout. The teeth are what they worked on over time. Because initially, you know, remember there was the accounting of disclosures. Well, you might find something inappropriate by looking at the or preparing an accounting of disclosures for a patient. These are all the non-TPO or authorized disclosures of information. But really, the penalties or the process were not as defined as they are now, and we will look at that. So the breach notification rule says that all breaches of PHI must be notified to the affected individuals and to the Department of Health and Human Services Office for Civil Rights. Notice I underlined all breaches because over time that has changed. Used to be breaches over a certain number. Now it's everything. So one breach, 1,000 breaches. All of them need to be communicated to the individual, meaning the patient, the individual whose health information was breached. And then it's also got to be reported. The reporting timeframes may change, and we'll look at that in a couple of slides, but everything has to be made known, which is a good thing. I mean, I would like to know. Sometimes it's kind of overwhelming, isn't it, when you get that letter and you're like, wow, now what do I do? Well, we're going to talk about that. The HITECH Act, which is the last series of legislation under HIPAA, did a couple of things. It strengthened the encryption standards. It actually provided encryption standards. So remember how we talked about at the beginning where administrative simplification standardized? What does a claim look like? What does a referral look like? It provided the electronic code information that makes that standard. So everybody's claim has the same fields, right? Well, encryption, same thing. It's one thing to tell you, hey, make sure you encrypt your information, as opposed to now the law saying, and here is the level of encryption, and these are the standards you need to reach. And that's got to be programmed into your system. They also defined workforce, right? Because we think of workforce maybe as employees, but people can be independent contractors. So is that part of the workforce? Okay. What about volunteers? What about students? They're not being paid. Are they part of the workforce? And so the High Tech Act said, you know what? Everybody's part of the workforce. If they're there and they're authorized to be doing something on your behalf in your organization, they are part of the workforce, whether you pay them or not. And the protections. So the protection for how long you have to protect PHI, I think it was something like 50 years, and it's basically was changed to indefinite. So for however long that information lives, the standards of protection for use, disclosure, business associates, all of that is now indefinite. All right, so notification requirements. We said that the first person who needs to know is the affected individual. And there are standards for how you tell them. So by first class, meaning US mail or email, but email only if the patient has in writing stipulated that they're allowing email communications. And then there are still guidelines for needing to follow up if they're, uncontactable, things like that, needing to send them information and reach them by a second means. So you can read that if you're interested. Can't sleep at night, read the HIPAA law. You need to do this without delay, and certainly no later than 60 days from the date that you discover the breach. You need to provide a toll-free number that's got to be active for at least 90 days where patients can call to find out. Think of the letters that you may have gotten from, a bank or an app or a store or whatever that says, hey, we think a breach happened and we think your information's been disclosed. Well, how do I find out if it has or not? Call the toll-free number and give them your information, and they will tell you if your information was part of the breach. The other thing is that you need to describe the breach, like what happened and the information that was breached. It was your credit card, it was your social security number. What information was accessed by someone else? And what should the patient do to mitigate any harm? So I know when I've gotten those breach letters about, something that included my financial information, they'll say, and you're entitled to, a free credit report or whatever, or credit monitoring, whatever, that I can access in order to make sure that I limit the harm to my account, to my financial self, all of that. So that's got to be part of the notification. I will tell you, as a healthcare manager, you will not be doing this by yourself. Absolutely not. Why? Because usually these are things that are going to involve legal counsel for the organization. So if you discover a breach, you escalate it through your organization, and I've seen this in the real world, if you will, and it does include the legal aspect because you've got to protect your organization. Because what's the first thing that I want to know when I hear about this? Okay, so your information got hacked and my info's out there. Great. What are you going to do? Number one, how did this happen? Like technically from the organizational standpoint. What did you people miss? What did you mess up? What employee did something wrong? And why? And why didn't you spot it? And now how are you going to fix it and make sure it never happens again? So there's a lot to be done, because if you think that when you notify HHS, they're going to say, oh, thank you for letting us know. Have a nice day. And that's never going to come back to, and how are you going to make sure this never happens again? You're being a little bit naive. So See how this is handled in your organization, and know that there's a lot of documentation and recording of what you did, what you found, when you found it, that needs to go into this, and you will never go wrong by taking that tack. So a description of the breach, the info that was breached, and the steps to mitigate harm. However, you also need to notify the media. And if you're a little bit horrified, yeah, I know, but there's got to be a press release sent out that if the breach affected more than 500 residents of a state or a jurisdiction, same deadline, same information. So this information has to go out from the company that goes out on the airwaves that so-and-so had a breach, it affected 652 people, blah, blah, blah. This is what happened, and they toll-free number, all of that. And notify the Secretary of HHS. If the breach affected more than 500 people, then you fill out an online form with the same deadline. If it's less, then you can kind of collect that information in the organization and report it annually to HHS, no later than 60 days after the end of the calendar year. So if it's only dribs and drabs of people, and I say that with a little bit of humor, you can kind of store that and, disclose it once a year. Of course, you could disclose it when it happens too. So now, I know you were thinking about the business associate. I could hear it. I could see it on your faces that I cannot see. That you thought, well, wait a minute. So this all affects the covered entity who has the responsibility to comply with HIPAA. But the business associate does too by virtue of providing services to a covered entity. So what happens if a business associate has a breach? Because they've got to do the same things. They've got to make sure they've got the protections, the technical safeguards, all of that. Well, first they've got to report the breach to the covered entity. And the covered entity is responsible for the notification. Now, in some cases, if the covered entity approves it, the business associate may handle the individual notifications, but the covered entity is responsible for media and HHS. And the same time frames apply. So one more thing about that. So part of the business associate agreement is going to spell out to the business associate, hey, if you have a breach, this is what I'm expecting from you, and this is the time frames that you have in order to notify me and tell me what you did or didn't do. Now, there are some exceptions, and exceptions to the breach aspect are unintentional breaches. Now, I'm not going to get into, because not an attorney, don't play one on TV, I'm not going to get into the nuances of what makes it intentional, inadvertent. This comes from the law, and so use these definitions as you wish, and guide yourself by the policies and procedures of the organization that you work for. So unintentional means that the person that works for the organization was doing something that the person was permitted to do, and they had the authority to be doing it. And they acted in good faith. They were doing their job, but you know what? It was an unintentional disclosure of information. And the information cannot be further used or disclosed. So it was leaked somewhere, but it can't go past there. So that would be an exception to not count it as a breach. If it was inadvertent, so the information was given to somebody who was authorized to access PHI at another covered entity, and the information cannot be further used and disclosed. And I will tell you, gosh, long time ago, this happened in our company where an employee was supposed to be emailing something and was supposed to email it, I'm trying to remember to whom. And you know how like when you start typing an email and you put like the first letter, people from your contacts come up whose names start with that letter? Well, he wasn't paying attention, and I don't know why. His girlfriend's email address was in the email program, and he ended up sending PHI to his girlfriend. Yes. Now, fortunately, he disclosed this right away. So as a business associate, because our company is not a covered entity, we had policies and we had done training and all of that. So he knew to say, hey, I messed up. It turns out his girlfriend worked for like LabCorp. So she was somebody who was authorized to access PHI at another company, and she did not access the information that we sent. So that could be an example of an inadvertent um, disclosure. And the third exception would be if the disclosee, right, the person who received the information is unable to retain the impermissible disclosure. So maybe it gets wiped from their system. So then at that point, it's not able to be shared. And so, and in our case, the inadvertent, it was a password protected document. So that kind of limited the ability to access it. All right, so there are penalties. There's always penalties. And the penalties come in kind of like three rungs. I spell them out here, but then I found a really interesting little graphic that's a few slides in from another company that posted it. And it's got the same information, but it's a lot prettier and more memorable. So you'll get to see that. But basically, the penalties apply for a couple reasons. One, the organization didn't know that there was this vulnerability, let's say. And even if they had exercised reasonable diligence, they still wouldn't have known. So then the penalty is $100 for each violation. So think about, if there were, 1,000 patients' information was leaked or hacked. And as long as you don't have other instances of the same thing happening, then the fines will not exceed $25,000 in a calendar year. Let's say that the violation was due to a reasonable cause. I mean, we can understand how this happened, but it wasn't something neglectful that the company did. Then it goes up to 1,000 and total amount not to exceed 100,000. The third violation is due to willful neglect. So as a healthcare manager, there are things that you are supposed to know. And if something wrong is being done in your department or your organization as a manager, chances are you should know about it. You should know that something's going on. Why? Because you are managing and you know the rules and you're checking up on people and you're checking up on work. So there are things that you should know, and then sometimes there are things that you don't want to know. So knowing and not doing something about the issue is big. So here we've got willful neglect. So you missed it. It wasn't reasonable that it could have happened. This is something that you should have known happened and you didn't, and now you're horrified, but you're going to fix it. And you fix it within 30 days. You go back, you figure out what happened, you make changes to your policy, you retrain your staff, all of that. You made the correction. You keep good records. Well, it's a slightly higher fine for each violation, and as long as you don't have violations of an identical requirement or prohibition during the calendar year, well, your losses are set at $250,000. Now, if you didn't correct it within 30 days, you could see that the numbers are much higher. So what does that say to you as a healthcare manager? You need to step up your vigilance, right? And it's hard to do because we know we're pulled in a lot of different directions, a lot of things going on. You're juggling chainsaws during the day, but there are some things that you need to have your ear up, you know, like radar, and walking around knowing what people are doing. Oh, last thing. If the action is successful, person, which is really your organization, could be liable for the Department of Health and Human Services attorney's fees. That was a little bit mind-blowing to me. So if they do prove that your organization had this breach, it was willful neglect, holy cow, you could have to not only pay your own attorney, not only pay these crazy fines, but on top of that, have to pay for their attorney's fees. So, FYI. Here's the graphic that I told you about, and the source for this is Secure Frame. And you can see that it's really easy to read, kind of easy to remember. And notice that, yes, there could be criminal violations and penalties, but those are for things that are like deliberate, right? Deliberately obtaining and or disclosing PHI without authorization. Your cousin has a new company selling something and you extract, not you, because I know you wouldn't do that. Somebody who works with you, right? Took information out of the system and gave it to their cousin, not even your cousin. All right, tier 2, obtaining PHI under false pretenses. Oof, hacking, right? Maybe using somebody's password, like after you've left or something like that. Obtaining PHI for personal gain or with malicious intent. I'm not even going to get into how those things all play out, but you can see that, you know, people could spend from 1 year to up to 10 years in jail for these types of deliberate acts. So, in summary, you know a lot more about the HIPAA law, I hope, than when we started. So privacy and security, you know, patients put their trust in us and in our healthcare organizations, and so these things are crucial. We are the keepers of the flame, right, as managers. So we're the ones on the front lines, making sure that that everything that our organizations, all the frameworks that our organizations have put in place, are working. They're like good, and they will prevent any kind of breaches, unauthorized entry, loss of information, and they will protect the information that your patients trust that you have, right? Hopefully you know enough to protect your organization, your patients, and your workers. Compliance doesn't have to be a burden, but you can see that this is really much more involved than sign here when you pick up your prescription and, you know, don't talk about people in the hallway. I do want to include the sources that I used for this presentation so that you know. U.S. Department of Health and Human Services, CMS, Code of Federal Regulations, Snoozeroo, if you need to fall asleep at night, read that. American Medical Association. I did access this HIPAA journal, which had some good information, and then that little graphic from Secure Frame. All right, I think you guys are all set. Thank you for watching.